We'll start then, sir.
Yeah, start, I think.
Yeah, I'm ready.
Okay. Good evening, everyone, and welcome to the last session of this series of Tenacious Tuesday teachings, which is our 11th edition. And we have a very interesting topic that we are taking up today, very necessary, often not covered during the general PG curriculum because of lack of time and focus on many other things related to general psychiatry. And we are in for a treat today because our speaker is genuinely someone who's special in terms of how practically and how simply he can put things to us. So for today's session, we have our chairperson, who's Dr. Deepak Tiwari, sir, who's professor and head of Department of Psychiatry at the GG Hospital, Jamnagar. Sir, if I can hand over to you to introduce our speaker for today.
Good evening. It has been a pleasure to introduce Dr. Bhushan. I have been fortunate to meet him also at Pune, I think, in an exam also. And he has gifted me a book also written by him. It was a pleasure, sir, to have again see you on and listen to you. Sir has been very well trained, I think. That is my understanding. And it would be a pleasure to learn from him about children. Child psychiatry is a topic which is very important because of nowadays we are seeing cases also being kept in almost every exam, even in DNB as well as in MUHS also I'm seeing cases being of child psychiatry. Apart from that, daily we are going to see some patient and we are at our wits end how to approach them, especially children. So I welcome you, sir. And there are so many things you are doing. I'll just read out that one is Satyamev Jayate. You have been there, as well as you have been very well trained in CBT, person-centered play therapy, systemic therapy, medical hypnosis, and you work with children and adolescents at various systems like judiciary, family court, as well as you have helped many people in orphanages and schools also. You are a good writing also for newspaper and increasing awareness through TV and radio also. And this book would be very interesting for me also to learn about LGBTQ IA plus community. We are very much interested and we did a small research at our place also. Sir, the stage is yours. Thank you. And we are, most of us are very willing to listen to child psychiatry. Sir, thank you.
Thank you, sir. That's a very, very generous introduction after we met at the exam last time around. So, okay, everybody, welcome to this special educational session. I hope everybody is able to see me properly here.
Yes,
sir.
yes.
Yes, sir.
Yes, sir.
Thank you. And are the slides visible as
Yes,
well?
sir.
Can you see?
Yes, sir, they are visible.
Lovely.
And sir, just as you're starting, if I can just put out to all watching there, if you have any questions, please do share on the chat box. We can address them towards the end of the session. And as always, we have a feedback for the session, which I'll be sharing the link in some time. So please do put in your feedback as well. Thank you, sir. Over to you.
So I have deliberately added that second line to the title. The title that is given to me is Approach to Assessment of a Child. And what I have added is a private practice perspective. And I think it is necessary for me to first explain why I added that. As we know that assessment in child psychiatry itself is a fairly lengthy process and involves a lot of other things in it as well, other than just the clinical interview. And the ideal assessments or what should be done, the guidelines are available with American Psychiatric Society. Our Indian Journal of Psychiatry came up with a special issue, and that did contain a very comprehensive paper on what is the most ideal way to assess a child. Now we know that even in the Apex institutes, the most ideal conditions are not present. It is difficult to do assessment by that protocol, but it stays there as our ideal. In private practice, the situation is even more complicated, because at least in an institution, there are multiple layers and multiple professionals present there before psychiatrist himself or the child psychiatrist himself sees the patient, himself or herself. In private practice, you are the only one there. And in the typical Indian way, no matter how much you plan to gather a lot of information before you physically meet the patient, more often than not, it just lands in front of you, and there is no other help available. So, and again, you may get that single chance. The first consultation becomes very crucial, because without that, nothing is going to move on. Unless that consultation goes well, you are not going to get your patient back for the second session and all of that. Plus, as we know, worldwide in child psychiatry, particularly where people are self-paying, the follow-up sessions are very rare. Many times child psychiatrists get only 1 or 2 chances to actually help the patient. So things get quite complicated in child psychiatry. That is why the assessment that I'm talking about, the approach that I'm talking about, is specifically from a private psychiatry perspective. How do we go about it in the clinic? So comprehensive biopsychosocial assessment happens over many sessions. We do not expect to complete the entire assessment in the first session itself. Even the most generous private practitioner will not be able to give more than 30 to 45 minutes for the consultation. So it has to happen over multiple sessions. The main aim of child psychiatrists there is to be a conductor of this orchestra of other professionals, family members, and the school as well. And we have to remember that this is one of our most important roles, to be the conductor of the orchestra. Second thing that one must remember is that every session, no matter how long you are seeing the patient, is a brief assessment where we look for negative evidence and contradictions. For example, I have, say, for example, in first session that I conducted with parents and with school report and all of that, I am suspecting autism in the child. But the moment child approaches me for the second session, I see the child smiling to me, happy to shake my hands, sit down, make a nice eye contact, and play in the playroom that I have here. So let me just give you a quick look, if it is possible to see for you from there. This is a playhouse. It's a fairly big one. It's about 4 foot tall and 4 by 4 by 4. A child can actually go in and sit there. And this is my clinic room. If you see there is a lot of empty space there where a child can actually walk around, and there are no tables and anything there. Okay, so this is the room, and let's say the child walks in, greets me very happily, and chats with me or interacts with parents very meaningfully. This is a contradiction to what I had heard last time. So I have to be ready for that. Second is the negative evidence, something that this particular disorder is not supposed to do, and the child demonstrates that sign right in front of you. Then this is also very important for diagnosis. So we keep on refining our diagnosis and challenging our own diagnosis in every session that we see the child. We do not assume that whatever I have written here is the final say. As Alan Francis, the ex-president of American Psychiatric Association and editor-in-chief for DSM-3R and DSM-4 said that when you write a diagnosis in child psychiatry, it is better to write it in pencil, at least for first few months, and only then write it with a pen, because there is a very high chance that you will actually change the diagnosis as you go along. This is something that is very important to remember. Now, what is the reality of a clinical assessment? The first consultation, the most important thing that should happen is like an emergency room. There has to be triage. This is a crucial skill. Unless we have triaged properly, we have done the quick assessment and decided what we need, it cannot move on. So within first probably 10 minutes or so, you should have the most probable diagnosis or formulation in your head that you will modify over the remaining session. Second is you should be able to do risk assessment very quickly in first half of the session, because this changes your management strategy completely. So a quick risk assessment to see if the child is a danger to themselves, are they a danger to someone else, or are they in a situation which is potentially abusive or neglectful, is something that must happen very quickly in first few minutes. Third is demand versus need assessment. That parents or the agency that has brought the child to you may have certain demands, but the need of the child may be totally different. For example, the parents may demand that my child must join us for dinner every night, or must tell us everything that is going on, or must attend the school every day, whereas your assessment shows that the child is suicidally depressed. So the need here is not the child joining the family for dinner, but the child staying alive while you treat their depression. So the need versus demand difficulty has to be understood very quickly. And fourth, by the end of the session, you should be able to have an agreement with the family or the agency that has brought the child to you on a plan of action. So this is your target for first session. And I'm going to focus this entire presentation on that first session because that is the best chance you have. Here we come to the most important aspect that all child psychiatry patients present with. Everything is reported to you in terms of behavior. All difficulties in children manifest in behavior. This is literally the final common pathway of expression of growth of the child as well as distress of the child and what is happening around the child. So everything that is reported to you typically is reported in the form of behavior, either stuff that the child does and parents think that is problematic, or stuff that the child is supposed to do, but the child doesn't do it and parents see that as a problem. So literally the entire assessment is based on reporting of the behavior of the child. So obviously we need to know what is normal behavior. And this becomes very tricky for new trainees because they themselves have recently finished their adolescence or young adulthood. Most of them actually do not have a lot of exposure to children. Now we have a generation of people coming into medical college or coming into training for psychiatry or even starting private practice who have had absolutely no exposure to young children. Their own data of normal behavior usually is either their own assumption or whatever they remember from their own childhood. So what we need to know here as a young trainee or as a young psychiatrist is age of the child is one of the first things that we need to know. No child psychiatric consultation can start without knowing the correct date of birth of the child and age of the child on the day of consultation. This is absolutely fundamental. Without this, the consultation is a non-starter. Because say, for example, a child demanding to sleep with parents would be perfectly normal at 1.5 years of age, maybe slightly dodgy at 3, definitely problematic at 5 to 6, and grossly abnormal at 15 or 16. So same behavior, depending on the age of the child, will be totally different. Another thing that we need to remember here is when we talk about age, we are talking about mental age of the child, not the physical age. Because at least 10% of the children that you see will have intellectual disability and their mental age will be significantly different than their physical age. And this will be factored in when we make the management plan. Second thing is situation. Definition of normal behavior is totally situational. What is absolutely okay at own home may not be okay at a relative's home, may definitely not be okay in school, and may be absolutely disastrous in a social situation. So normality depends on age, depends on situation, depends on culture as well. Particularly in India, we have a mix of cultures. And many times, even in the so-called cultures, there are multiple subcultures. Every family has its own norm, and these norms may be completely contradictory to each other. So before we decide on normality, we also need to know what goes as normal with that particular family or their subculture. And the last point about normal behavior, and this is the tricky one, are the expectations. What is the expected normal behavior from the family? And does the child fit it or not? Now, will you call it abnormal just because it does not fulfill family's demands? That's a different thing. But these are the 4 things that you need to know. Now we come to the next point. How do you assess behavior? Because typically parents give very difficult answers, non-specific answers, or sometimes even completely wrong, misguided, or confusing answers to your questions. So most of the data has to be gathered indirectly. So there are a few ways that I follow in the clinical assessment when I'm interviewing the parents to know about behavior of the child. First is I ask them to describe the typical day of the child in very minute details. And let me give you an example here. Typically, you ask the parent that, can you describe your child's typical day for me from morning till night? And the parents will say that, oh, he goes to school in the morning, then he has tuitions in the afternoon, he goes for play in the evening, and then he has dinner and goes to sleep. Now, this is not at all good enough for me. What I'll ask is that, at what time does the child wake up? What time does he need to wake up? Say, for example, they say he wakes up at 6:30 in the morning. My next question will be, does the child wake up on his own, or do you need to wake him up, or is there an alarm? Now, if you need to wake him up, how is the process of waking him up? How quickly does he wake up? What happens in the morning once he has woken up? How much time does it take to get ready? How much do you need to go after the child to get ready? What extent of help is needed? Then if the child goes to school, how does the child go to school? In a bus, in a rickshaw? Does somebody drop him? Does the child walk to the school? Do you go to the bus stop to drop your child, or does your child walk by himself or herself? How is the child in the transport? Are there any complaints from there? Does the child report anything while going or coming back in the transport? And so on and so forth. It will be absolutely great details of everything that the child does from the moment they open their eyes till the moment they go to bed, and even after that, about how do they maintain their sleep? Are they a peaceful sleeper? Do they walk? What happens when the child wakes up? Who does the child go to when they wake up in the middle of the night, etc., etc. So going through the child's day from morning till night and their sleep routine pretty much gives you everything that you need to know about the child, and should be able to make a very confident diagnosis at the end of that. Second thing that I want to know when I'm assessing behavior are the relationships. Typically, parents are a little bit better about reporting relationships. So we need to specify these 3 areas: that how are the relationships at home, who is the child closest to. It is also important to ask, who does the child does not get along with at home, or who do they not talk to or prefer not talking to or try to avoid. This gives us very important information. Then similar thing about school and other relationship like friends or on the playground or tuition teachers, etc., etc. Third crucial question to ask the parents is, how do you get things done from this child? If you want certain discipline to happen, or if you want the child to do certain thing, usually how do you manage that? And ask them a detailed example of something recent that they tried to change or they tried to make happen, and how did the child respond to it, and how did they respond to the response of the child. Now this is getting into real details. Say, for example, the parent says that I wanted my child to start studying in the afternoon, so I gave him a timetable and he has to study from 4 o'clock till 5 o'clock. But he did not study at all. He continued to be lazy and continued to waste his time totally. So how did you respond to your child not obeying you? Then the parent will say, okay, I gave him a big counseling session, this, that, and the other. So the next question is, so what happened after that? No, my child did not obey me at all. My counseling was wasted. He still just plays his video games from 4 to 5 in the afternoon. So how do you respond to this reality? So going into their responses to each other's behavior is something that is really important, because this will give you the details of how communication, discipline, and behavior patterns work in that particular family. And the last thing that we specifically ask about are the conflicts. That what are the conflicts that the child faces, Is there any evidence of the internal conflict of the child? Do you see that? Do you understand that? Does the child communicate that conflict to you, and how it is handled? So this is something, if you are able to get these 4 things done, you have pretty much done a very comprehensive assessment of how the child is living their life in the family, in the school, and outside the school as well. Now, before I finish the consultation, there are 2 very important questions for me to understand. First question that I ask the parent or the child, if they are self-referred, is what is it about this behavior that is troublesome for you, and how? This is an important part because their pain point or their way of looking at the problem, their perception of the problem or their perception of what is problematic here is really important for me as a clinician, because not only it gives me an understanding of the family, but from a practical point of view, unless their concern is addressed, I'm not going to see this family again. Obviously, if their demand is unreasonable, then I have no way of fulfilling that. I may try to educate them, but some aspects of their demand may be perfectly rational, and I will have to address that as a psychiatrist. Second question that I need to know for myself is, why have you decided to look for help now? Particularly when the problem is going on for some time, what pushed you to take professional help at this point of time? That will invariably tell you what is the tipping point for that particular family. And it is important to know that. I will not go into details of this, but this is something that I do go on with all the parents to understand what is the temperament of the child if I'm looking at somebody who's up to 6 years of age. Because the detailed assessment of temperament itself gives a lot of insight to the family, and they are able to understand what the child brings to the table. When the child is older than that, typically, I mean, we have that gray zone there from 6 years till almost 12, 13 years of age, where nothing can be concretely put into either temperament or personality. But for an adolescent, I definitely use the Big Five model and sometimes try to use the online questionnaires that can be filled in 5 to 6 minutes and can give you a graphic illustration, or actually ask the questions one by one to try to understand personality of the child. If the time permits, and if I'm suspecting some specific personality patterns in the family, I would go on asking about, does the child match anybody in the family on this particular parameter, etc., to get a general idea of how this particular family functions. I will not go into details of temperament of personality models here. I'll assume that all of you are aware of it. So I have talked to the parents, I have talked to the child, I have done that preliminary assessment. It is almost 20 minutes, 25 minutes by then. Now, at the end of that, this is something that needs to be clear in my head to know how it is going. I need to look at the dynamics that is presented in front of me. So where does the child stand in his developmental stage? What is the psychological state of the child at this point of time? What is the environment like? What is the temperament / personality of the child? And how all 4 of these interact with each other to produce the symptoms, to produce the notability of the symptom and the reaction of the family. Now, this is the dynamic thing that I need to understand. There are times when I actually take a printout of this page and add points at each of these areas and share it with the family, so that in their mind, they are also able to differentiate what is coming from where. And then they can direct their efforts accordingly or decide to tolerate or ignore that particular part. With most of the families, even illiterate families are able to understand that these are 4 big areas that interact with each other, and they make up difficulties for my child. Even if they are presenting to you for something which is purely behavioral, like my child has recently started smoking and what can I do about it, dividing it into these 4 parts and going beyond the biopsychosocial model really helps the family here. Now, depending on how what I'm going to present next is a totally made up thing. There is no, you will not find this in any textbook, but these are the 3 big clusters that present to you in the clinic, particularly for children who are older than 6 or 7 years of age, or maybe pre-adolescents and adolescents. This is how it typically works for everybody. These are the big clusters that present. First is the school and the academic cluster. Here the presentation is because the child is poorly performing in the school and in the academics. There are poor study skills. Not only that, a lot of unwillingness from the child to study, and there is poor overall discipline. This is what they report to you. Now, what are you looking for here? The commonest issues which give rise to this are attention and concentration issues. Either the academic intelligence is problematic or learning disabilities are present. What I mean by academic intelligence is that some children who are otherwise socially quite adept and smart may not have the hang of the academic system. We all know as medical students that some people write the exams really well. In spite of not having a huge amount of knowledge, you may not trust them with your life, but they know how to crack exams, they know how to study. And this academic intelligence is not present in every child. So a child with lagging academic intelligence is invariably going to start falling behind, or at least their grades are going to dip as the school gets more complicated, typically 6th, 7th standard onwards. And parents have their mind calibrated that this child scored 99% in their first standard and second standard, and now they are dipping down with every year. So this is something that is a common presenting thing. And what are the other strengths in the child? So many times the child has other strengths like love for literature, like love for games, like social skills, like organizational skills, and they get diverted towards their strengths, which is a very natural thing to happen. And that causes academic and school difficulties, and parents are very unhappy for that. So this is the first cluster, or a lot of patients come from this cluster to child psychiatrist. Second is the social behavior cluster, where the complaint from the parents are typically about friendships of the child. That the child is either making too many friendships or getting befriended by people or making friends who the parents don't see as a good influence on the child. The media usage pattern or the entertainment patterns of this child are also something that these parents don't like. There is clear disengagement with the family. The child is more engaged with the outside world or the online world than their real life family, and discipline and obedience have become big issues. Now, discipline is obviously self-discipline, and obedience is following the commands at home or in school or on playground. Now, this is what parents are unhappy with. As you can clearly see, this would be a much older child, typically adolescent, early adolescent child. So here the issues behind that may be the temperament of the child or the personality of the child, the way it is developing may be very different than parents' temperament. So they see that as a problem. Introverted parents having a highly extroverted child will invariably see that as a problem. There could be a very clear axis 1 pathology emerging here. There could be depression, there could be anxiety disorder, there could be conduct disorder emerging, or it could even be a presentation of a child who's developing bipolar mood disorder. So it can be anything from axis 1. Again, we also need to worry about the family discipline, family cohesion, and family style. Where does the child fit into this, or is the child a normal outlier for this particular family? And the third one, which again presents quite frequently in psychiatrist consulting room, is the individual behavior issue, where the child is usually very introverted. Child has very high anxiety levels, plus or minus avoidance. So they could be avoiding a lot of things which a child of that age is supposed to do. There may be instances of self-harm, and their high school performance starts dipping. So till the middle school, the performance is quite good, but as they reach high school, the performance starts going really bad. And one clear thing that you see with these children is they show aggression only at home. Outside the home, in the school or on the playground, they are absolutely biggy-billy, but at home, they can be very aggressive, either verbally, emotionally, many times even physically to the parent. And this child on parent violence is something that we see very commonly all over the world, particularly in India. There are a lot of psychiatrists in the West who have studied this very actively. One notable person is Dr. Girish Vaidya, who hails from Solapur but now works in Sheffield, has done a lot of work on child-on-parent violence. Now, parent-on-child violence is something that everybody talks about all the time. But this other thing, like domestic violence, is extremely destructive for the relationship. It completely decimates the self-esteem of the parent. And many times as a child psychiatrist, you need to step in there and help these parents, because axis 1 disorders in parents start emerging once the child-on-parent violence starts. So this is something that we need to look at. The typical issues, again, are temperament or personality issues there. There could be significant family pathology, particularly personality disorder in one of the parents, or substance misuse in one of the parents, or economic difficulty. Attachment style is a huge issue here. There could be significant attachment issues between the child and the mother. Initially, there would be a lot of insecure attachment, which the mother feels very gratified about, that how the child is very well connected to me. Then it becomes an ambivalent attachment between the child and the mother from the child's point of view. And later on, as the child is trying to break away from this suffocating attachment, they resort to violence because they don't see any other way of getting away from the mother. So axis 1 pathology in the child is also very much likely. So these three clusters are the common presentations in your clinic, particularly for older children. So here we come to the end of first session, first assessment session, and this is my last slide for the presentation. So what do we need to know by the end of first session is I should have a process diagnosis in my head. What do I mean by process diagnosis is this particular thing. What is the interactional model? What is the process that is actually happening here? And what 4 things are contributing to this particular presentation? So this is my process diagnosis. Second is my discussion with the family about this process diagnosis. I educate them about how things are going. I address their concerns, tell them what is coming from where, how it will be addressed, what will need to be tolerated, what can be modified, what needs to be treated. Then correction of the environment, particularly for risk management. So if I have assessed any risk at that point of time, if I have become aware of any risk, then I need to modify the environment accordingly, give very specific instructions to the parents about how that environmental modification is expected. For example, keeping a vigil on the child, dropping the child to school and getting them back, or even arranging with the school that the child will be handed over to one of the school authorities and then picked up from the same place. This becomes a big issue when we are talking about children with school refusal. If it comes up in the question, we may be able to talk about that later on. And then specific interventions and assessments that I have planned that will help me come to a proper diagnosis. So first is the psychometric assessments that I'll send to. I know that everybody has their own favorite psychometric assessments or a battery of psychometric assessments that they get done. I won't go into details of that, but please make sure that you get these assessments done from a qualified psychologist who has a RCI registration number, and they give a printed report to the parent. Now, this is something which has posed a lot of ethical issues, because there are many psychologists who do not give report at all, or just prefer to discuss the report with the psychiatrist on the phone directly. We have to remember that, like a lab report, this is something that belongs to the parent. Parents must have a properly printed and signed document of that report. This is their right, because if they change the doctor, they go to somewhere else, they need to have these reports with them. Second is advising specific psychotherapy. Now, this is again something that is where we really have a lot of difficulties, because a generic counseling is offered to many children. And there is enough research to prove that generic counseling is not only a waste of time, in some cases it is actually harmful, because it trivializes severe, serious problems. So when the child is sent for therapy, there has to be a very clear discussion between the referring psychiatrist and the psychologist about the formulation of the case and what specific work will be done. It is good to commit about the type of therapy that you are going to do. It may be just supportive work, but it has to be done very specifically, and there has to be a clear label and some kind of time frame, because otherwise the child going there every week talking to the psychologist about how their week was, and the psychologist kind of doing listening and communication module on the child really does not help. That is not counseling. When specific psychotherapy is needed, that is what has to be administered, not just generic patient listening ear for the child. Then family therapy or family work that is needed, this most likely will be done by the psychiatrist, which is about troubleshooting, which is about focusing on communication patterns. This is about specific behavioral tasks. That is something that it advised to the family. And the last part is the pharmacotherapy. Again, I'll not go into details of that because each of this component will make an independent lecture by itself. But appropriate pharmacotherapy is absolutely vital in all the cases, whether it needs to be started right on first session or sometime later, that is your clinical judgment. But by the time these patients actually reach a child psychiatrist, a very large number of them are going to require pharmacotherapy as well. And we will have to work that out with the patients. So this is how it typically goes for the first session in a private setup. Takes about 30 to 45 minutes. As you can see, this is a lot to cover in those 45 minutes. So your phone should be switched off, or with the receptionist, you should have full privacy for those 45 minutes. There is going to be a lot of to and fro, like first you will interview the child or the parents, and later on you will interview the child again. Then you will be getting all of them together in the room again for the last part and discussing your plan. Sometimes the parents will come all by themselves for the first session and the child will not be brought. It is desirable in many cases. So you can actually ask your receptionist to tell the parents only while they are taking appointment itself that your child is 12 years old. Would you prefer to talk to the doctor alone first and not bring the child? Because many times detailed discussion is required with the parents for first session itself. So this is how it goes. I hope this is helpful for you. This is obviously not ideal, but this is what usually works in a single clinician private practice, where you need your patient to come back to you, not only for treatment, but for the follow-up as well. So that is how it goes. Thank you very much. All yours, Sri Lakshmi.
Thank you, sir. You've, as always, been very pragmatic and crisp to the point. Tiwari sir, you have anything to share, ask?
Dr. Bhushan, sir, I would like you to give an example or sort of a case vignette of, it would be very helpful for all the students about whatever you have discussed till now. Probably it may be in second session, I don't know, but if it is possible.
Yeah, sure. So let me give you an example of a patient that I saw today. So here, a typical Indian scenario, here is a 16-year-old boy in 11th standard. He came to the clinic with a senior woman who was his mother's age probably. And he came in by himself. The lady waited outside. And he sat in front of me and he told me that my Atya, that is my father's sister, has brought me here. And so I asked his name, got the other details from there. As it usually happens, my software was malfunctioning, so I did not have any other details on this child other than his name and his age. So I started gathering information from him, and then I asked him, why are you here? What is the reason you are brought here? And he said, I don't know. Now, this is not an unusual response, right? Anybody who has worked with adolescents will tell you that they have no clue why they are there, or even if they have, they will play, difficult there. So I said, so how do you want us to proceed? Now that you are here, you have read my name on the clinic board, and here I am a child psychiatrist. What can I help you with? He said, I don't know why I'm here. So I said, typically children are brought here by their parents, or sometimes they come here by themselves when they have emotional difficulties, relationship difficulties, academic difficulties, etc. Do you think one of these areas could be the key issue why you are brought here? That is when he gave a smile. And then he told me that he actually wanted to pursue football. He was a star student in school. Unfortunately for him, academically, he was phenomenal. He scored something like 98% in CBSE in 10th standard, and his parents obviously wanted him to join IIT JEE, which he had joined. But He was barely attending it, not doing very well. His parents stay in a faraway village 250 kilometers from here, and they have kept him at his Atya's place for education. Now, here is a situation where there is no axis 1 pathology clearly. Here is a situation, here is a young man who's extremely intelligent, very smart, excellent social skills, who is in a difficult situation. And he wants to pursue his football. He wants at least 1 year to be given full time to football. He wants to take a sabbatical, and his parents would have none of it. And that has frustrated him to such an extent that he has started harming himself. Now, though self-harm is the presenting thing here, we know that this child is in distress. He's in a conflict situation. So what is the next thing that I do? Is after I have done preliminary assessment to rule out depression, severe anxiety, and any kind of suicidal behavior or suicidal thoughts, I've done my risk assessment. I call the aunt in. I tell her that this is the situation and I definitely need to talk to the parents. So she says, why don't you talk to them on the telephone just now? So now see, these are all the things which do not happen in Western countries. This is a typical Indian consultation. So she dials the phone. I talk to his parents who are 250 kilometers away. So at the end of the session, where are we? I have a clear diagnosis there, which is mainly about conflict. There is no axis 1 diagnosis here. Then I know that the child is at a developmental stage where he's actually exploring almost as an adult his environment. He has his own clear desires. Psychological state is of deep dissatisfaction with the family and severe conflict with the family, where he feels nobody understands him and his life is wasted. He is thoroughly frustrated and he's expressing his frustration by harming himself. Then the environment where he is a very conducive environment where his Atya is a very nice person. She's a very gentle person, but she does not have the parental authority. So where this goes all of now is that I call the parents, I tell them that, see, I know you are far away, but this cannot be solved without a family meeting face-to-face happening here. So as soon as it is possible for you, please do come over. Meanwhile, I ask the child that let us meet once more so that I can explore this process a bit more and I can understand where you are coming from. So that you and I have a clear agenda of what we are going to discuss with your parents when they are actually here. I'm going to join the session as your ally or your voice, and we will see rationally what is possible. So this is the resolution at the end of the session. This is typically a consultation goes where there is no clear diagnosis, but a child is presented with self-harm and a very serious conflict. So when will they come back for next session? I really don't know, but there is a good 70-80% chance that I'll actually get to work with this family. But this is how it happens. So this is approaching it more from a systemic point of view than from a purely biopsychosocial model. I hope, sir, this kind of serves as an example there.
Thank you, sir. There are some questions.
Yeah.
Suggest further reading on process diagnosis.
Okay, so the one book that I find very helpful is Goodman and Scott's book on child psychiatry. See, I mean, I trained in the UK, so I have huge influence of the British way of thinking. And obviously, if I have spent so much of time there, I got to declare that I really like it. Okay, the fact is that I'm more familiar with it, so familiarity breeds that comfort for me. So I would definitely suggest Goodman and Scott's textbook. The first few 2 or 3 chapters about understanding child psychiatric diagnosis, understanding development, and seeing the process at work is something that I really find useful.
Dr. Sri Lakshmi, madam, we can move to second session, or?
So we have Toli Bhushan sir's session today. We can take some more questions or maybe request sir to share some more. So I have a question, if I may. Very often when it comes to adolescent age group, like beyond 12, 13 onwards, there is this situation that comes up where parents suspect substance abuse. They may have found something or heard from someone, never broach the subject at home, directly bring the child for a consultation and just say, this may be happening, please find out. So what would be your suggestions or tips on how to go about that subject with the child?
Honestly, this is a fairly common situation. There are two types which are really difficult situations. One is when, as you said, you are given the job of an investigator or a jasus. That here is a case. Now tell us what is the truth. So you are Sherlock Holmes there. And second type is where you are Daud Ibrahim. They come to you with supari कि इससे ये करवाना है तो अभी आप करवाइए kind of thing है हमारी सुनता नहीं है आप करवाइए. So either you are Sherlock Holmes or you are the mafia don who has taken supari to get something. So typically it is good to walk out of both of these situations and have a clear understanding with the parents, getting basically fair details from them. So in such case, I would typically tell the parents that unless I talk to you in detail, I don't think I should be interviewing the child. So if you want, I can just do the first rapport building session here, but I need details from you. Because half of the times, there is absolutely no evidence of anything happening on the substance misuse front. And parents being extra cautious or something like that. So that goes away with parental counseling. But when it actually is suspected, then my next step is to assess it with the parents, what kind of risk or conflict tolerance they have. Because any kind of assessment, direct questioning of the child, and maybe biochemical confirmation of that is going to lead to conflict. And so this is like a pre-test counseling for parents, that unless they are willing to tolerate that conflict, unless they have the ability to handle that conflict constructively, I'm not going to go ahead with the next step, which is interviewing the child. Let us assume that they show adequate resilience there, they are ready, and then I talk to the child. Many times, particularly with adolescents, it is absolutely helpful to be upfront and clear. Now, this is what is being suspected. Why do you think your parents are suspecting that? So I'm not asking that child to confess. Tell me whether you are using it or not. I am saying what could have made your parents suspect this. That is when the child is going to talk about his behavior, etc., etc. Then I get a chance, then the child gets a chance to see that I am a truly non-judgmental person there. And then I have some chance of winning their confidence. I get a chance to tell them that unless I see that you're in clear physical danger, confidentiality very much holds, and I'm happy to help you. And then the conversation can move further. But asking the child, why do you think your parents suspect that you could be using something, is one of the key questions here.
I think, sir, you have answered one of the questions about rapport building in your last statements. And are there further any ways in which we can build up? That was the question from one.
Yeah. So typically what I have seen is a rapport building is, though we know it's the most vital thing, it is one of the most difficult things. Because many times the child is brought there with certain things told to the child, and that itself destroys it. So when you get a chance to talk, my rule of thumb is that if parents have brought the child with them, I'm going to talk to the child first and then talk to the parents later. And this is very open and clear. And so the child, and I give the open invitation to the child that I don't know why you are here. I don't know what your parents are going to tell me. So help me understand what is happening here. Many times the child is totally foxed, they have no idea what is happening there. So you start exploring it with the child. That how are you doing in this area of your life, that area of your life? Do you think this is the reason your parents are worried, or that could be the reason? And I use that session with the child. One thing that I definitely do is, and I don't know how it is going to sound at the receiving end, but please bear with me, is I don't talk to the child in a condescending tone. I treat them as equal adults. I don't use baby language. Another thing is I don't try to be excessively friendly. I don't try to use their language or their slang just to appear very friendly, because I'm a clear adult. I mean, I've got white hair. Come on. I can't pretend to be an adolescent's friend. All right. So it is, I'm here, I'm happy to listen, and I'm not that dangerous. I can actually be useful to you is something, if that is conveyed to the child, then the rapport building can happen. Not giving into parents' agenda, giving the child adequate time, is something that usually works. That again, not always, they are very difficult. There are good 10-20% kids who simply disappear after the first session, and then you have to continue working via the parents. So that is very much part of the job, but one must make an effort.
One of the questions is how much is the possibility of a deeper issue being present with respect to self-harm in this case, which you were discussing there?
Yeah, it is very much possible. There could be various things going wrong there. What I assessed at this point of time is that how dangerous is this self-harm, and is it a sign of distress or is it a sign of suicidality, which is the most important thing for me. And if I get more opportunity with this particular young man, I would obviously take him up for therapy or maybe even DBT. And before that, I'll do a therapeutic assessment, therapy assessment, and try to find out if there is any conflict or deeper issue that I can find. But this is all that I managed in the first session in about 30 minutes that I got.
Sri Lakshmi madam, over to you.
Sir, since we have PG students here, maybe you could just give a little brief idea, maybe in terms of, you were talking about age appropriateness in terms of the history and trying to figure out. How about when we are talking about rapport building or talking? You spoke about how you would not speak in a baby language or to the child, but certain questions or certain things would have to be asked in a way that the child would understand. So maybe you can give some insight into that.
So for people who are just starting out interviewing adolescents or young children, there is one specific questionnaire that can help. It is called HEADS, HEADS. And this is something that is actually used by pediatricians, community pediatricians. So it gives you detailed questions on various aspects of a child's life. So it is about their health, it is about their school, it is about even their sexual exploration, drugs, friendships, family, studies, etc., etc. So you can use those templates of the questions to start with. And as you get comfortable with asking those questions, use your own language. One thing that I have found useful is that no two child psychiatrists actually have the same assessment process. As it is, we psychiatrists are extremely personalized people, right? We don't do things by the rote. In child psychiatry, it gets even more personalized, and everybody develops their own style of questioning, their own sequence, their own pattern. Literally what happens within first 5 minutes, decide what you are going to do for next 25 minutes or 40 minutes of the session. So my suggestion to them is that use the HEADS as the initiator of the interview. Don't use CBCL like things which are too diagnostic and practically quite useless to use in a clinic. So get in a conversation, try to have a regular conversation. One thing that has helped me is to have the curiosity, to have genuine curiosity, is like, actually, what is happening in this 14-year-old's life? And that genuine curiosity does carry to the child. They see that as empathy and they're happy to discuss. So just being curious is something that really helps. And I don't know how to practice that. Probably just talking to more and more kids helps.
We're talking about curious and how to talk to kids. So there's a question that has come in about someone who's seen a 14-year-old child today who confided about polysubstance abuse. So they're asking about how could you counsel the child about drug use, especially in cases of adolescence?
So again, I have very serious objection to the word counsel because of two reasons. One is the original use of the word counselor in English was an elderly gentleman in your family who was pretty much in charge of your life, and you had to follow everything that he said. He was usually the uncle who was going to give you your inheritance. They were called as counselors. Okay, so my counselor or my governor is the word that young people used to use. Those of you who have read P.G. Wodehouse must have come across this word very often, right? So that is not the role that we play. Second is the counselor, as now medical admissions are called counseling. There is a counseling round where you are actually told what to do, which is again total nonsense. And the third word is actually being a salesman. where you have certain idea in your mind, and this is essentially supari that you are trying to execute. So I would definitely go against the word counsel here. My aim with a polysubstance using child is first is to do risk assessment, and second is to develop very deep rapport with this person. Let us accept this reality that somebody who at 14 is doing polysubstance abuse has probably seen a lot more in life in their 14 years than my 50 years put together. Let's have respect for that. And then I want to explore, I want to see how things are going, exactly if there are any legal tangles that this child is likely to get into. Are there any serious physical difficulties that are really imminent there? Say, I have worked with very serious substance misuse clients in the UK. I worked on a trial where we made available injectable heroin on prescription for 6 months. And these were people who had failed 20 years of de-addiction services. And I worked on that trial. So I realized that a lot of substance misuse people actually have a very strong personality, a good philosophy about life themselves, and are not usually given in to just our degrees and our socio-economic status. So we need to be equal partners there, work with them for multiple sessions before the change can happen. And the more non-judgmental attitude that you have, the more collaborative attitude you have, and the more harm reduction attitude you have, there is some chance that you will be able to help this child. You go in with this agenda that I'm going to counsel this child out of their polysubstance misuse, you're not going to see the child again. So extreme patience, a lot of time, and willingness to engage them at the level that they are. That is what I would look at.
As always,
Thank you,
sir,
sir.
giving us a lesson beyond just what the topic is. There is a question related to certification in private practice.
Right.
Go about, or what do you recommend in regards to that?
So, see, I've been doing my exclusive child psychiatry practice since 2008. And before that, when I started my practice in 99, a large part of my practice was child psychiatry. It has taken me almost 5 years to put together a team of psychologists, a psychotherapist, a speech therapist, occupational therapist, social skills trainer, and all of that. Unfortunately, though they are very well qualified, what they say has no value from government's eyes. So if you are looking at certification of disability, then obviously the child has to go to government hospital and get it done. That is the law. If you are looking at giving them certification that will help in their exams, board exams, 10th and 12th, so then we know that CBSE and ICSE accept private certification provided it is done by a current RCI registered psychologist. IB and IGCSE also accept private certification, again with the same conditions, provided you do the specific test that that particular board requires. For example, again, I'm not horribly up to date on that because my teammate is a very able psychologist, so I don't even have to bother with these things. I think they want something like Woodcock-Johnson 3 or 4, which is, in my opinion, a totally useless test for an Indian. But if that is what they need, that is what you need to do. There you go. So that is how it is done. For state board, Maharashtra state board people, we fortunately are able to send them to Sassoon Hospital, who are very happy to accept our assessments as a part of the process and not just throw it in the bin. They use it as a helpful document. So that is what it all boils down to.
So we hear from many students, just pass outs who come as SRs, that we're into child psychiatry. We are thinking about doing a fellowship or a DM in child. So do you have any, like who can take up child psychiatry? Is there anything like that? Like, is it any characteristics in the doctor?
That's a difficult one because when I wanted to do child psychiatry, there was no child psychiatry training available in India, except the 3-month assistantship that you could do at NIMHANS. There was literally nothing available at all. So I had to go to UK, stitch my own postgraduate training together and get the experience that I wanted. I came back in 2008. Fortunately, I think 2010 is when DM was started at NIMHANS, and now a lot of fellowships started after that. So I think it's a very good spread available now. So my suggestion is that go ahead and give a try for a fellowship. One thing that you will realize very quickly is that I'm being very candid here with fellow professionals. If you are genuinely interested in doing your own clinical practice, where you see the patients yourself, you have put the team together and you actually work 8 or 10 hours a day, there is very little money in child psychiatry. Okay, there are only so many patients that you can see in a day because they require a lot of time. There is very little prescription practice there. There are almost zero admissions. Even with the kind of workload that I have, I don't need more than 10 or 12 admissions per year. So first is that you have to be really passionate about children and their mental health, and you are not too focused on buying your Mercedes very quickly. If that is your focus, then you need to actually put up a big center and do all those assessments, necessary or unnecessary or whatever. That is where the money is. So that is the first thing. Second is you have to be genuinely interested in the psychotherapeutic process, because child psychiatrists simply cannot exist without very intensive psychotherapy training. If you are ready for that, then that is something that can really help. It's a very rewarding profession. I'm very happy that I chose it. And if I get a second chance again, I can guarantee you this is what I'll do again. Okay. So if these things are okay for you, you're going to be a good child psychiatrist.
Thank you, sir. I think there are no more questions that are left. So usually, since this is a PG activity, at the end of the session, we kind of have a small 4 to 5 round questions just to kind of put to practice the things that have been talked about during the session. So people around who are there, you can answer in the chat box. We look at the answers there. And of course, these histories that I've put together are not as in-depth or detailed or anything that sir was just talking about. It's just for the sake of giving you a run through in terms of putting together what we have learned about assessment. So here we go. Master A is a 5-year-old boy brought by his mother to the clinic. She's concerned about his poor communication abilities. He does not maintain good eye contact. He does not play with other children and has no friends at all. He also does not share anything with others. So what further questions would you like to ask in this case? That's one question to you all. This time I've not made it MCQs actually. And what is your likely diagnosis? If someone can help me with the chat box.
Oh, I'm so glad I'm not the student anymore and I don't have to answer questions.
It's not very difficult, sir. Yeah, I can already see some answers coming in. People are talking about birth history and developmental details. Yes. Clinically judge about IQ level. Okay. There's one answer which says assess for ASD. Give you guys about a few seconds more. Any more further answers? So yes, this does raise some of the red flag signs for autism spectrum disorder. Typically onset before 3 years of age with impairments in reciprocal social interaction, communication. Here, if you'd see, there's not much about any repetitive behavior or restricted patterns. So those are also things that you may want to explore in the history and try to get a further idea about. And of course, you do have scales to help you through, like if it's a toddler less than 2 years, there's MCHAT. There's also CAS, ISA, that can be helpful tools for you to kind of get a basic idea about the symptoms and features of ASD. Okay, moving on to the Next question. If anyone can identify this concept, what is the likely age group of this child? And once you know the concept, the theory is not very far away. Concept, I can see names for who gave the theory. These are some things, I mean, I don't know whether sir would agree with me, but these are some things I find good when we are talking to the child, because it helps us kind of remember. Of course, children do fall on either side of the spectrum, but having this in mind, I think, is something which is good when you're interacting with the child. I
Let
can
me
see.
show you this. This is a plastic glass. You know, in a typical child psychiatric clinic, you will definitely not find those glass things there. You know,
Yes.
yeah, there is no breakable stuff in my clinic at all.
Safety first. Yeah, so only one person I think has answered yes. The concept is conservation. Age group, which we're talking about, I can go on to the concrete operational stage. Yes. So it's a very nice concept that we talk about when we say that though these two things are in objects of different uh, shapes and sizes, the child is unable to tell that the amount is the same. The understanding that the same quantity, even though the appearance changes. So yes, now the answer is coming. 7 to 11 years. Yes, in fact, pre-operational and concrete is more or less where we put them, and the concept is conservation. Okay, go on to another case. Miss B, a 10-year-old girl, is brought by her mother with complaints of refusal to go to school. Mother reports that these days she often loses her temper and spends more time at home, usually complaining of headache or stomachache. All investigations and checkups so far have been normal. What may you think of? I know diagnosis is a far leap, but at least what could you have as differentials, or what could be your suspicions? Okay, I can see some answers starting to come in. If I can have some more people answering. So there's somatic complaints, there's school refusal, there's irritability. Okay, so childhood depression is what I've got as the answer, and yes, unlike adults where typically you talk about them reporting low mood, depression in children can often present with irritability, clingy behavior, and a lot of somatic complaints. So exploring along those lines, yes, somebody's mentioned academic difficulties. That is something that very often with such children, when you explore, you do find the child having problems like learning disability, which have not come up until you actually look into those aspects. So a woman brings her 11-year-old son to your clinic saying that he's very anxious. He takes exceedingly long time to get ready in the morning. And an interview with the child reveals that he has silly thoughts that come into his head, which he dislikes. Sorry about that. Which he dislikes, and he has to do specific things to send them away. What could you think of in this case? I think this is pretty much straightforward. Though I believe this particular disorder in this age group is not as easy when you're seeing a child in the clinic. Yeah, so I can see answers of OCD coming in. So yes, it's more or less straightforward. I don't think it needs an explanation, which brings me to the last case that we've kept for today. 14-year-old girl has changed a lot in the last 6 months, according to her mother. She isolates herself in her room most of the time, talks to few selected friends on her mobile phone. She spends much time on the internet chat rooms and social networks, and has little conversation, if any, with her 7-year-old brother and her parents. But her academic progress has been satisfactory and no other major changes have been observed. What do you think in this case? internet addiction, okay? Maybe. I think we need more details to come up to that diagnosis per se, though it's not actually on any classificatory system at present. Anything else? This is actually quite typical, something which parents come to. Social anxiety, okay, maybe. Any other answers? But very often, normal adolescence is what presents in this way. If you talk to the child, if you do an assessment, there may not actually be anything problematic at all. It is just a regular change in behavior which the parents perceive. So I think, like Sir very well put for us today, I just thought this would kind of summarize the whole thing. If we go step by step in that manner, we're talking to the child as well as talking to the parents, getting both their perspectives, I think that will go a long way in helping us decide, because first we need to figure out what is normal before we can go to the abnormal. So with that, we have come to the end of the activity. So I must say a big thank you to Bhushan sir for, as always, being very practical in his approach and helping us all learn a little bit more into child psychiatry today. Like I said, the little humans are definitely not easy when it comes to dealing with. So thank you for that. And thank you, Dr. Tiwari, for last minute coming in and covering as our chairperson and helping us get through our session today. Of course, it was Neena ma'am and her Zid, I must say that my question to ma'am was, ma'am, it's 10th, it's mental health day. Everybody is going to be busy with something or the other. Ma'am said, no, if the speaker is available, we are going to have the session on 10th, and we did. And I think there's no better way to celebrate mental health day than learn a little more. So I think many of the people who joined in are also consultants, not just PGs. So everybody did make their time, ma'am. So thank you everyone. And Yogendra ji has helped us with the tech support, building the flyers and all of that. So thank you so much to him and his team as well. Nimisha ma'am, Neena ma'am, if you have a few words for us, as this is the last session of this edition.
Yes, sure. Say the last words. Thank you, Bhushan, for a wonderful session. It was necessary because skill building is what we look at Tenacious Tuesdays. And Sri Lakshmi said the practical session was needed. I agree that textbooks and history taking, which we teach at institutes, is far different and a very different approach from what you said. But yes, I think hearing you was necessary. So thank you, Risha.
Thank you.
Is she there?
Thank you, ma'am. Thank you, Bhushan sir. It was really
Lakshmi,
nice.
is she there?
Yes, ma'am. Ma'am.
Yes, ma'am. I'm here. Am I audible?
Yes, ma'am. You're audible, ma'am. Nimisha ma'am, I can.
Yes.
Okay. So, sir, really, I learned also, the interactional model and the perspective, the process. So it's really practical, sir. So thank you so much. And it's definitely helpful for the residents also. Thanks
Sir,
a lot, Lakshmi ma'am.
you are now booked as a speaker for further.
Yes, definitely. And if the topic is related to child psychiatry, the first name would be Dr. Bhushan, sir.
Thank you.
Thank you so much. And thank you, Neena ma'am. Thank you, Sri Lakshmi ma'am.
Yeah.
Thank you.
Thanks a lot
Very,
for
sir.
this
Thank
chance.
you, very, sir. Yes.
Thank you, Neena. You had booked me a year ago, and that
Yes.
is phenomenal. For somebody who's so scattered as me, this is phenomenal. So thanks for keeping me in the line. Thank you, Sri Lakshmi.
Yeah, good.
And thanks a lot, Tiwari sir. It's been lovely to have you as a chairman.
Thank you so much, sir. Thank you, everyone. Neena madam, Nimisha
Yes,
ma'am,
good night.
and
Thank
Sri Lakshmi
Good
madam.
night.
Thank you.
Thank you. Thank you.
Happy
Good
World
night.
Mental Health Day,
Yeah.
everyone.
Bye.
Yes.
Good night. Thank
Good
you.
night.
Thank you.
मीटिंग एंड कर देंगे. Stop the recording.